Good evening to all, and thank you for joining a virtual community lecture brought to you by Providence. Our focus this evening is on hip and knee pain. I'm Tom Burton. I'm a physical therapist, but also the executive director of Orthopedic Sports Medicine and Spine, Clinical Institute for the South Division. Our guest speakers this evening are joint care experts Jeevan Sall and Dr. Nirav Shah, Dr. Jeevan Sall and Dr. Nirav Shah. And before we get started, I want to let everyone know that this is an hour-long presentation. We will have plenty of time for questions at the end, and we want you to please use that question and answer box to type in any questions you might have, and we'll do our best to get to each question by the end of the presentation. Please note, we are not able to answer personal medical questions, but certainly we'll answer general hip, knee related questions. If we're unable to answer your question, please feel free to email calectures@providence.org. Now, we're going to be placing that information in the chat for you, so no need to write that down at this moment. And it will be included at the end of the lectures, as well as any contact phone numbers that we might be able to provide. We will try to do our best to be able to get back to you at our earliest convenience. Now, Providence has 17 hospitals across California to care for all your medical needs, especially when it comes to your hip and knee pain. By bringing together expert physicians, experienced nurses, and highly skilled therapists, Providence provides complete hip and knee care. From physical therapy and pain management to surgery, our expert orthopedic surgeons can help you restore function and improve your quality of life. You can feel confident knowing that Providence can care for both you and your family. Lastly, we want our attendees to know that the information provided during this program is for educational purposes only. You should always consult your healthcare provider if you have any questions regarding a medical condition or treatment. Now, it is my pleasure to introduce Dr. Jeevan Sall. Please welcome, for Dr. Sall, please welcome Dr. Jeevan Sall, an esteemed primary care sports medicine physician with an expertise in non-surgical orthopedics, particularly in sports injuries and in joint pain, such as osteoarthritis. His dedication to promoting, with extensive experience working with athletes of all ages, from high school sports teams to the older weekend warriors and professional athletes, Dr. Sall is a true expert in his field. As a high school and college physician and an active volunteer in his community, Dr. Sall continues to make significant contributions as a sports medicine physician at numerous sporting events. His dedication to promoting health and well-being among athletes is commendable and has earned him an immense respect within the sports and medical communities. In his free time, he enjoys traveling with his wife and playing pickleball and golf. And today we have the privilege of learning from Dr. Sall's vast knowledge and practical insights as he serves as one of the distinguished lecturers for this session. Let us warmly welcome Dr. Sall as we embark on this enriching virtual experience together.
All right, thank you for that kind introduction. As mentioned, I will be speaking about knee and hip pain and non-surgical management options. So let's jump right into it. Here is an overview of what I'll be going over today. I will briefly speak about the anatomy of the knee and hip joints, followed by reviewing osteoarthritis and how it is diagnosed. I will then go into more detail about the many non-surgical management options for knee and hip pain with a focus on osteoarthritis. Primary care sports medicine specialists undergo extra training during a fellowship to learn about non-surgical orthopedic medicine, including training on the workup, diagnosis, management, and prevention of muscle and joint injuries, concussions, and have expertise in physical rehabilitation and the role of exercising in promoting a healthy lifestyle. We treat athletes of all ages, including school-age athletes, professional athletes, weekend warriors, and older patients with osteoarthritis. Now the hip and knee joints. So the knee joint is the largest joint in the body, consisting of the femur, which is the thigh bone, tibia, which is the larger bone in the lower leg, and the patella, also known as the kneecap. It is a hinge joint that enables flexion, which is knee bending, and extension, knee straightening, allowing activities such as walking, running, and jumping. The hip joint is a ball and socket joint, connecting the femur, again the thigh bone, to the pelvis. The knee and hip joints have space between them. In the knee joint, that space consists of the meniscus, which is made up of cartilage. In the hip joint, the joint space is made up of the labrum, which is also cartilage. Joint cartilage is a smooth, firm, and flexible connective tissue that covers the ends of bones within a joint, providing a cushioning and facilitating movement. The knee and hip joints also contain joint fluid, called synovial fluid. In a normal and healthy joint, synovial fluid serves to lubricate the joint, reduce friction, and provides nutrients to the cartilage, aiding in shock absorption and smooth movement. In a joint with osteoarthritis, the synovial fluid may become thinner and less effective in providing lubrication, leading to increased friction, stiffness, and reduced shock absorbing capacity, contributing to joint pain and impaired mobility. Additionally, the synovial fluid in osteoarthritic joints may contain increased inflammatory components, further contributing to joint degeneration and pain. So on the screen, you see two photos, two x-rays. On the left is a knee joint, and on the right is a hip joint. You can compare the normal joint space of a knee and hip joint on the right, and then on the left, narrowed joint space, which is osteoarthritis. So osteoarthritis has been known as a wear and tear condition, but in actuality, it affects the entire joint, including bone, cartilage, ligaments, and synovial fluid, which we just talked about. Osteoarthritis can degrade the cartilage, change the bone shape, and cause inflammation, resulting in pain, stiffness, and loss of mobility. Risk factors to develop osteoarthritis include age, gender, obesity, weak muscles, overuse of the joint injury, and genetics. How to diagnose osteoarthritis of the hip or knee. So a primary care provider may be the first person you talk to about your knee or hip pain. The provider will review your medical history, which includes discussing your symptoms and how the pain affects your daily life. They will look at and move your joints and may order imaging. So x-rays are a quick and low-cost imaging tool that can show joint or bone damage, including changes related to osteoarthritis. As a sports medicine physician, I always make sure to order weight-bearing views for my patients. This means to take some x-rays with the patient standing, in addition to lying on the x-ray table, to show the true joint space loss of the knee or hip joint. So MRIs are not needed to diagnose osteoarthritis, and they do not usually change the initial management plan. They can be expensive and time-consuming. However, MRIs may be helpful before surgery to get a better view of the extent of the joint damage, including views of the cartilage and other soft tissues. In regards to osteoarthritis, symptoms tend to build over time rather than show up suddenly. Symptoms include pain or aching of a joint, usually with activity. For instance, my patients usually say they have hip or knee pain when walking their dog, getting in and out of their vehicle, playing soccer, golf, or tennis, or even shopping at Costco, which we all know involves a great deal of walking. Other symptoms include joint stiffness, usually occurring first thing in the morning or after resting for a prolonged period of time. Limited range of motion that improves after movement or stretching, clicking or popping when a joint bends, joint instability. So for instance, when you are walking and all of a sudden you feel your knee or hip going to buckle or give out. And lastly, joint swelling called effusion. Osteoarthritis may affect different parts of the body in different ways. So with the hips, sometimes a patient may feel pain in the groin area or buttocks, and sometimes on the inside of the knee or thigh. And then with the knees, a patient may feel a grating or scraping feeling when moving the knee. We will get into non-surgical management options shortly. But first, I want to get real and talk about one of my patients that I have been seeing in my sports medicine clinic. So Nancy. Nancy's a delightful 73-year-old female patient who was referred to my primary care sports medicine clinic for right knee pain and on and off knee swelling that had been getting worse over the past few months. Her symptoms worsened when playing pickleball and with ballroom dancing. As you can see, I listed her specific risk factors, which is her age, her gender. She had some muscle weakness on exam, potential overuse with pickleball and ballroom dancing, and then genetics. She also had told me that her mother had osteoarthritis as well. So in clinic, Nancy's history and physical exam indicated likely osteoarthritis. So I performed x-rays in my clinic and reviewed them with her the same day. Her x-rays confirmed osteoarthritis. We then discussed management options for her symptoms. So unfortunately, osteoarthritis cannot be cured or reversed. However, I tell my patients that we can help manage their pain symptoms and try to delay progression or worsening of the osteoarthritis with many conservative management options. Conservative management means non-surgical options. And I usually split this up into two categories, non-pharmaceutical and pharmaceutical. This basically means non-medication options and medication options. I like to have a detailed conversation with my patient and go over all the management options to find a combination that works best for my patient's symptoms and lifestyle. So let's get started with the non-pharmaceutical options. Exercise is an essential part of osteoarthritis treatment plan. Modify your activity as needed for less symptoms. Home exercise programs or physical therapy can help by strengthening muscles around the painful knee or hip joints and help ease the stress on them. Weight management. So excess weight puts additional force and stress on the weight-bearing joints, including the knees and hips, and fat cells promote inflammation. Losing extra weight helps reduce pain and slows joint damage. Assistive devices such as canes or walkers help by offloading some of the body's weight on joints and can prevent falls. Braces such as hinged knee braces can help with pain and stability. Patient education serves as a foundation for promoting active patient engagement, improving treatment adherence, and enhancing the overall management of hip and knee osteoarthritis. It empowers patients to take an active role in their health and well-being, leading to better treatment outcomes and a higher quality of life. There are also complementary and alternative therapies that I like to discuss with all of my patients, such as diet changes and supplements. Osteoarthritis is just one of many inflammatory conditions, and therefore I recommend diet changes that promote anti-inflammatory foods and avoiding foods that can cause inflammation. There are also many supplements that have anti-inflammatory effects, such as turmeric and omega-3. Some of my patients swear by glucosamine and chondroitin joint supplements. While their efficacy is still a subject of debate, they are believed to offer certain benefits, primarily due to their roles in joint health, such as cartilage support, reduced joint pain, improved synovial fluid, which is the joint fluid, and slowing the progression of osteoarthritis. Both ice and heat can also help alleviate the pain associated with hip and knee osteoarthritis. Ice works by numbing the area and reducing inflammation, which can help to alleviate acute pain. Heat, on the other hand, helps to relax muscles, improve blood flow, and reduce stiffness and discomfort, providing relief from chronic pain. Therefore, I personally like to recommend ice followed by heat for episodes of pain and swelling caused by osteoarthritis. And lastly, acupuncture, ultrasound therapy, and red light laser therapy are alternative treatment modalities that are sometimes used as complementary approaches in the management of hip and knee osteoarthritis. While their exact mechanisms of action are still under investigation, they are believed to offer certain benefits that can help alleviate pain and improve joint function. Now we will discuss the pharmaceutical options, which means the medication options for knee and hip osteoarthritis management. So analgesics is a medical term for pain relievers that includes medications such as acetaminophen and opioids. Acetaminophen is the generic name for Tylenol, and this is available over the counter. Opioids, which are stronger pain relievers, but can have more adverse effects, including addiction, must be prescribed by a doctor. An example of an opioid prescribed for osteoarthritis is tramadol. Next, we have NSAIDs. So NSAIDs are the most commonly used drugs to ease inflammation and pain. They include medications like ibuprofen, also known as Advil, naproxen, the brand name is Aleve, and meloxicam, or Mobic. NSAIDs have a better anti-inflammatory effect than analgesics, but can have more potential adverse effects, such as stomach discomfort or acid reflux, and they can negatively affect your kidneys and heart, especially if taken for prolonged periods of time. This is why I only like to recommend oral pain medications as short-term solutions for osteoarthritis to my patients. Oral steroids, also called corticosteroids, such as prednisone, can help reduce inflammation in joints and therefore help alleviate pain, swelling, and stiffness. It is essential to note that the use of corticosteroids should be carefully monitored by a healthcare professional due to the potential risks and side effects associated with long-term use. These side effects may include weight gain, increased blood sugar levels, and the risk of osteoporosis, among others. And lastly, joint injections. I honestly believe that joint injections are an excellent way to manage osteoarthritis symptoms. Knee and hip injections are low-risk, quick procedures done in clinic. They are localized, meaning that the medication mostly stays and works in the joint to which they are injected, whereas oral medications can affect the whole body. There are many different types of injections, as listed here, and I'll go over them more in detail on the next slide. This table has a lot of information, but you will see 4 popular injection options for knee and hip joints. The table briefly describes some of the pros and cons of each injection, but there are many other considerations prior to selecting which injection is right for each individual patient. I usually do not recommend injections as the first option for management. When I have a patient with knee, and for instance, knee pain due to cartilage damage or osteoarthritis, I always recommend management with less invasive options, as previously discussed, such as physical therapy, weight management, diet changes, bracing, oral medications and/or supplements, and alternative therapies. If these have failed and are not controlling the patient's symptoms, then I may recommend trying an injection. Also, if a patient is in too much pain to undergo rehabilitation exercises or physical therapy, then I also may recommend an injection earlier to help to help the patient be able to perform the exercises that can actually improve the symptoms in the long run. So if an injection is indicated, I usually recommend starting with the corticosteroid injection because they can provide rapid pain relief, most often for over 3 months. Corticosteroid injections are also commonly called cortisone injections. I have had many patients who have had cortisone injections and have had pain relief for over a year. Also, this type of injection is quick, easy, and covered by most insurances. However, I usually do not do more than 3 to 5 of these injections in the same joint over a patient's lifetime, because with multiple repeat injections, there's potential for adverse effects such as weakening of tendons and risk of joint damage and cartilage thinning. If corticosteroid injections are not a good option for a patient, or if they are no longer working to control the patient's symptoms, then I'll usually recommend trying a hyaluronic acid injection or PRP injection. Hyaluronic acid joint injections involve the injection of a gel-like substance similar to the naturally occurring fluid in the joints called synovial fluid. This injection aims to supplement the natural hyaluronic acid in the joint, providing lubrication, cushioning, and shock absorption to improve joint movement and alleviate pain, particularly in cases of osteoarthritis. PRP, or platelet-rich plasma joint injections, involve taking a small amount of a patient's blood, spinning it down to concentrate the platelets, which are a type of blood cell, and then injecting this platelet-rich plasma into the affected joint. The goal is to use the natural healing factors in the patient's own blood to help reduce pain, promote healing, and improve the condition of the joint, especially in cases of osteoarthritis and other joint issues. Although both have variable effectiveness in different patients, they are both fairly safe and have potential to provide longer pain relief than corticosteroid injections. For instance, usually about 6 months for hyaluronic acid injections. Note that there are many different brand names for hyaluronic acids, such as Orthovisc or Synvisc injections, just to name a couple. Hyaluronic acid injections are covered by select few insurances, but PRP injections are not covered by insurance and can range from like $700 to $900 per shot, so they can be kind of costly. Lastly, stem cell joint injections involve the use of stem cells, often derived from a patient's own blood or body from other sources, which are then injected into the affected joint. The goal is to promote tissue regeneration, reduce inflammation, and potentially help repair damaged tissues in the joint, particularly in cases like osteoarthritis. Stem cell injections have variable effectiveness in patients, are not covered by insurance, and usually range into the thousands of dollars per injection. I do not perform these injections in my clinic at this time. Let's see, I want to finish my presentation with Nancy. So when we first met, she told me that she was not ready for surgery. After discussion about non-surgical management options, I made Nancy a personalized home exercise program that included exercises to stretch and strengthen the muscles around her knee. She also made changes to her diet to make it less inflammatory and started taking supplements, including turmeric and omega-3. She wears a knee brace while playing pickleball. Over the years, we had tried cortisone injections, which initially worked very well for her, and she had pain relief for many months in between injections. However, the cortisone injections started to not work as well as we wanted, so I recently injected her with hyaluronic acid. A few days ago, she sent me an update saying that the injections went well. She won her ballroom dancing competition and is beating 30-year-olds on the pickleball court. I'm really happy for her. Thank you very much.
Thank you, Dr. Sall, for that really interesting presentation. And it's just refreshing to know I'm a physical therapist by training, and it's just nice to know, aside from therapies, that there are a number of other modalities available to patients suffering from osteoarthritis that can really extend their time as they either optimize for surgery or continue to be able to enjoy their activities before potentially needing an actual joint replacement. So this has been great information. Now, it is my pleasure to be able to introduce Dr. Nirav Shah. Dr. Shah has been practicing joint replacement surgery for the past 9 years. After completing his undergraduate studies in biomechanical engineering at Columbia University, he attended Keck School of Medicine at USC for his medical education. And upon earning his MD, he completed his residency for orthopedic surgery at Albany Medical Center in upstate New York. Following residency, he moved on to complete an adult reconstruction, the technical name for hip and knee replacement, at the birthplace of modern hip replacement, the Anderson Orthopedic Research Institute outside of Washington, D.C. Dr. Shah's focus is practice towards complex joint replacement surgeries involving the most modern technologies and the most innovative, minimally invasive techniques. Today, Dr. Shah lives with his wife and two young children. His passions include playing baseball with his son, taking his daughter to dance and art class, eating delicious food his wife makes for him, and, of course, golf. Dr. Shah.
Well, thanks, Tom. That was very nice of you to say. Um, oops. So, my name is Nirav Shah. I'm an orthopedic surgeon in Southern California, and I am going to discuss operative management of osteoarthritis. A question that most of my patients have when they come in to the office is, how do I know I have arthritis? My knee hurts, my hip hurts, my shoulder hurts, but how do you know it's arthritis if you aren't a doctor? So I tell people, I ask them questions like, just tell me when it hurts. My knee hurts when I'm sleeping. My hip hurts when I get out of the car. My knee hurts if I stay in the same place for too long. I feel like I cannot get my socks and shoes on anymore. Driving my car for any length of time is so unpleasant. My knee looks like it's bowing in or becoming knock-kneed. My foot doesn't want to stay straight forward when I'm walking. These are all typical signs of arthritis that patients may see that doesn't necessarily require a doctor to figure out what's going on. And then obviously the next question are, what are my options? Well, life really does not have to suck. Especially our elderly population have been raised in a world where getting older means having pain. And, we as a medical community are really working hard to change that mentality. We want people to understand that quality of life does not have to decrease just because you're, Medicare eligible. As previously discussed, non-surgical means of treatment can be extremely effective and for a long, long, long time, but eventually they do fail. And surgery is a predictable and successful process. Let's start from the top down. Hip bone is connected to the knee bone, so it makes sense. Hip replacement. Why not a partial hip replacement if only the cartilage on the ball has gone bad? As you can see on the picture here on the left, that when you do a partial hip replacement, you're putting in a large metal ball to replace the bone ball. And that ball articulates on the cartilage and bone already in your pelvis. It's a short-term resolution. The bony atrophy that occurs, atrophy meaning loss of bone, is a rapid process. I've gone back into partial hip replacements done by other people or myself and noticed that a good portion of the socket of the hip joint is already gone within 2 or 3 weeks after surgery. And it potentially could lead to another surgery. We do partial hip replacements for people with hip fractures because historically we've known that people with hip fractures tend to have a high mortality rate within the first year. And what we're noticing is as we get better at treating hip fractures, when we do half hip replacements, these people come back within a year or 18 months and say, now my hip hurts again, and now I need to have another surgery. Also, a big controversy right now in hip replacement is, do we use cement or not use cement? Cement is a fixation method for the stem that goes in the femoral bone or the thigh bone. Historically, cement has been used as a grout to make sure that you get immediate fixation. But as hip replacement has modernized, we found that cement sometimes is not a great long-term option. So bony ingrowth into implants is a more favorable option. Full hip replacement sounds brutal, but we're going to talk about it a little bit more here. So where do we start? An arthritic hip. As Dr. Sall already discussed, you get, deterioration of the cartilage, which leads to an inflammatory process, which can lead to bone loss, which leads to pain. And this is a little cartoon of an arthritic hip. That looks terrible. It doesn't really look that bad. And then on the X-ray, this is what an arthritic hip looks like. You see that there is loss of the joint space. These little dark spaces are where the bone is at, because it's a living thing. It actually is resorbing calcium from these dark areas and putting it into these whiter areas that will eventually support the weight and act as a strut, so that the places where the weight is actually going through the bone, that's where your body is depositing the calcium. What do we do? Well, a hip replacement, the intraoperative process of a hip replacement. I guess the first question that should be answered is, I'm sure a lot of you have heard, well, there's different ways to do a hip replacement. There's through the front, through the side, and through the back. Historically, through the back has been the most commonly used procedure. The reason for that is that it's a very reproducible surgery, in the sense that if you learn how to do it and do it well, the outcomes are very consistent. The downsides are you put the patient at a slightly higher risk of getting a dislocation. A dislocation meaning the hip ball pops out of the socket after surgery. So we've been working diligently over the years to figure out ways to mitigate that risk. We've changed our technique, improved our implants, but maybe one of the biggest improvements in that risk factor came in the transition to the what we call anterior approach, or through the front, where we use this torture device looking table to position patients to be able to put the hip implants, which are the same whether you go front, back, or side, and into the hip, but we disrupt the muscles and soft tissues much less, so therefore decreasing the risk of dislocation, which therefore decreases the risk of a poor outcome and a better quality of life for the patient. I always like to look at surgeries in a way where there's upsides and downsides. When all the upsides are on the patient side and all the downsides are on the surgeon side, I find that an ideal surgery, because the point of surgery is to improve quality of life. So if all of the downside of the surgery relies on me and my technical skills, and all the upsides improve patient quality of life, that is a perfect marriage of upside and downside. This is what we do during surgery, which people quite often ask. How do you know the parts are the right size? How do you know you're putting them in the right place? So the image on the right side there is a intraoperative image where actually all of those components you see are trials. They are not the real implants that will go in. They are all versions of the implant where we insert a socket into the bony pelvis. We put a trial liner inside of that. We put a trial stem inside the femur bone, and then there's a trial head. That's why that looks like almost like you can't see it fully. That is all, we do all of that, and then we take an image. Then we have a computer or a robot or various other technologies that will measure all of these things and say, okay, you have the right size, you have the right leg length, which means we're not changing how tall you are or how short you are. We're making sure that the distance between the pelvis and the femur is reproduced to where your native anatomy was. And once we're all happy, we can take these trials out, put new trials in, change various things, and keep tweaking things until we're happy. Once we're happy, you get this image on the other side, which is final implant, final ball. As you can see, looks very different than this see-through ball here. And the implant, as you can see, has this little collar, which is different than the brooch on this side. And now we know that what we did before we buy any implants, before we say this is what you're going to get, we know exactly what we're getting. And that is a huge, again, upside for the patient, slight downside for the surgeon. But again, as long as upside is there for the patient, we're happy. What we end up with, total hip replacement. So this is a picture of the implants. The stem here, this is made of titanium. The pink ball here, which is pink for everybody, boy or girl, is made of ceramic. And then you have the cup or the socket, which is made of titanium again. And then between this ball and the socket, which you can't see on this picture, is a plastic liner. This is what an X-ray of a hip replacement looks like. This is actually the same patient who we saw his arthritic hip earlier. What's next? Recovery, which obviously all the surgical stuff is very fancy, but what we really care about is recovery. A hip replacement is a great operation in the sense that the recovery is really all about time, more so than hard work, therapy, exercising, and I like to think of recovery in phases. The first phase of recovery, which takes about 2 to 4 weeks after surgery, is I want you free of all assistive devices, complete physical therapy, and return to driving. My second phase of therapy is the more advanced functions, returning to all activities without restriction, pickleball, golf, tennis. I like people to be a little bit restrained on the really high impact stuff like running, jogging, things like that until 4 months after surgery. And the reason for that is we have no good test to make sure that the bone has grown into the implant. But based on retrieval studies, which means studies that were done where patients had surgery and unfortunately expired at various times after the surgery, we retrieved the implants and saw that until 4 months, there's no way to really assure that an implant has grown in. So for that reason, I hold people back from really high impact activities for 4 months out of an abundance of caution. And my goal is that at 6 weeks post-op, you are pain-free. Moving on to the knee replacement. This is a little bit of a different animal. A knee replacement and a hip replacement, even though we talk about them in the same setting, they are very, very different operations. And the recovery is different. The discomfort is different. But when you finish and end up at the end game, you're in the same place. So an arthritic knee, as you can see here, this is a healthy knee, looks great. You got a little bit of degeneration here on the one side. This is the inside of the knee because we can tell by the bone over here, which is on the outside. Then you start to progress more and more and more, and the bone gets, disrupted. The cartilage is bad, and you get this. You can get this is a bad knee. You can see there's not a lot of space between the outside of the knee here and the inside. This is a really, really bad knee. As you can see, the bone is gone. Ligaments are not attached. This, essentially you're creating puzzle pieces because the bone is just wearing all the way through. So how do we treat this? Once Dr. Sall has finished his regimen of non-operative treatment, which is very effective, unfortunately, surgery becomes a part of people's lives. Partial knee replacements are a great operation for people who have single compartment arthritis. We divide the knee into 3 compartments. We look at the inside of the knee, the outside of the knee, and the area underneath the kneecap. If you have truly one compartment arthritis, which means just either the medial, the lateral, or the kneecap side, a partial knee replacement can be a very, very useful surgery because we can preserve function, ligaments, and normal mechanics of the knee by only replacing the one compartment. There are some caveats. You have to have essentially no history of inflammatory arthritis, like rheumatoid arthritis, lupus, those kinds of things, because those things do damage to the joint that we can't necessarily see on X-ray or MRI that can make the partial knee replacement unstable. Also, you have to have all your ligaments intact. If you happen to be a basketball player or a football player and had an ACL injury or a PCL or an MCL injury in the past, a partial knee replacement becomes a very risky proposition. Why total knee replacement? Although it's a bigger surgery and a slightly longer recovery, if you have more than one compartment that is affected by the arthritis, it is a very useful treatment tool. Again, if you have inflammatory arthritis, it's also a more reliable and consistent outcome, as well as previous ligament injury really precludes us from being able to do a partial knee replacement. So here's a patient of mine. He's that same guy with that really bad knee. This is him walking before surgery. So as you can see, his knee is not holding him up. He can barely move. So what we do in the intraoperative process, the partial knee, again, like I said, we are very isolated to a single compartment. So we see bad arthritis on the inside of the knee. We have to be very, very careful to preserve the rest of the knee. We can't damage the cartilage in the kneecap or underneath the kneecap or in the compartment that we're not working on. So it takes a little bit more time. People would think a partial knee is actually a faster surgery, but it's actually a slightly longer surgery because we have to be very careful not to damage other parts of the knee. And then we make our bone cuts using special tools that measure and guide us on where to cut. We create these beds for the implants, and then here are the implants, which are the shiny parts, and then you have the white plastic in between. As you can see, the kneecap is preserved, the other cartilage is preserved, and the ligaments are preserved. What do we do in a total knee replacement? It's not wholly different than a partial knee replacement in the sense that the partial knee, we're concentrating on one compartment. In a full knee replacement, we do the same thing just for all three compartments. And the instruments do that by helping us make the bone cuts in that need to be done. As you can see here, we expose the knee, look at all the arthritis, then we make cuts on the end of the femur bone, on the top of the thigh bone, and we put these caps. People think that a knee replacement is this giant operation where we just cut out huge swaths of bone and put in this mechanical contraption that makes up for your knee. But actually, a knee replacement is more like a resurfacing procedure where we put a thin metal cap on the end of your femur bone, a thin metal cap on top of your shin bone with a piece of plastic in between, and the same thing for your kneecap. And there are four major ligaments in the knee: the MCL, LCL, which are on the sides, and the ACL and the PCL. The MCL and the LCL are retained here and here. The ACL and the PCL are resected or removed, but the design of the implant actually recreates their function. And as you can see here are x-rays of what a partial knee will look like after. As you can see, we've preserved the outside of the knee here, but replaced the inside of the knee here. And then this is that same patient who could barely walk. This is his knee replacement afterwards. As you can see, we had to use extra metal and some rebar in the cement to be able to make up for that large defect in his bone. But when we were done, this is him 2 weeks after surgery. This is what we call a success story. So what's next? Recovery. First phase of recovery, again, like I said, I like to look at recovery in phases because it's all about your quality of life. First phase of recovery is 2 to 4 weeks post-op, free of all assistive devices, which means a walker or a cane, and return to driving, which, as we know, driving creates independence. Second phase of recovery is 6 to 10 weeks post-op. We want to complete range of motion work, which means we get the full range of motion that the implant design will allow. Now we're progressing in physical therapy with muscle strength, which means working on stairs, working on stamina, working on ability to do the higher level things, like if you have a SUV or a truck, being able to easily get in and out. And you feel like you're about to turn a corner, but you're really not all the way there yet. You're still like, I'm tired at the end of the day. I can't do everything I want to do. I'm still limited. And then you have the third phase of recovery, which takes about 3 to 4 months after surgery, which is return to all activities without restriction and pain-free. And honestly, a knee replacement gets better for about 12 to 18 months after surgery. So there are small incremental improvements for that entire time, which will really make you feel like you're getting your life back. And where are we going? Emerging technologies. Everybody's heard about robotics, and we are in the robotic age of knee and hip replacement. But we are working hard on getting past that stage and getting to something we call augmented reality, where the surgeon will actually wear a helmet on their head with glasses, and the technology will actually 3D map the bone as it's sitting in front of me, and will overlay where the implant should go, where I should make my cuts, where I should put my socket, what are the angles based on information that I've provided it. And this is really the future of joint replacement in the near term. Long term, we don't know where the possibilities are, but we are excited about the idea of using technology to make outcomes better and return you to your quality of life as soon as possible. Thank you very much.
And thank you, Dr. Shah. Absolutely amazing information. And can we actually, in seeing the amazing work you did on that individual, that patient, really can see that biomechanical engineering degree came in a tremendous amount of help going forward. So this has been an amazing time to be able to see both the conservative as well as the surgical approaches. And before we begin our question and answers, we have a few questions for you, actually. If you could please answer the poll that you will see appear on your screen. Please give us your honest feedback. We would be greatly appreciated. And we will go ahead and begin our question and answer. And feel free to continue asking questions in the Q&A box. We will do our best to be able to get to them. And I do know that Dr. Shah and Dr. Sall and myself have been busy trying to answer a number of these that we feel that we can answer without actually a full-blown evaluation. So sometimes it's very difficult to answer questions specific to a person's case. But ideally speaking, some of these have been absolutely wonderful as far as the questions go. And I'm going to go ahead and open this one up and kind of start with this. I'm going to give this to Dr. Sall. There's a variety of different viscose supplementation or hyaluronic acid styled treatments that are available. And, commonly, how do we decide which direction we need to go forward with for each individual patient? Is there specific things that you would look for to determine which one might be the correct injection?
That's a great question. Many of the viscose supplementation hyaluronic acid injections contain similar ingredients. They're just branded differently. Honestly, my first consideration is the patient's insurance and what's covered or what may be covered. Nowadays there are options for what we used to do is do usually 3 injections 1 week apart, and that would last for about 6 months. Now we have options for 1 injection that should last 6 months. It just contains more fluid. But again, it also depends on what's available and best option for the patient.
That's great. And I know that there are synthetic and natural injections that are available. Is there a reason why you might go one direction or another?
For me, studies show that both can work equally well. So it's whatever is best for each individual patient and insurance, honestly.
Great. Thank you for that. And Dr. Shah, there was a lot of questions actually in the Q&A in and around osteoporosis and again, thank you to everyone who did ask questions regarding that. And we'll take notes of that as a potential new topic, maybe as we start looking and planning towards 2024. But when it comes to a patient who's been diagnosed with osteoporosis, are we able to still do a knee replacement if they are dealing with severe osteoarthritis?
Yeah, that's actually a very common question that comes up. It is concerning for people. And osteoporosis is a concern when we're in surgery, but it is not a deal breaker. We can certainly, by knowing that there's a diagnosis of osteoporosis, when we're in surgery, there's a lot of assessment of bone quality that occurs. And there are various options that we have available to us that can mitigate the maybe lower calcification of the bone. We also take a little bit more care to make sure that we are not damaging the bone in any way. And but it is not a deal breaker for knee replacement or hip replacement.
Great. Thank you. Thank you for that. I'm going to go back to Dr. Sall in regards to cortisone injections. And maybe Dr. Shah, you'll be able to add into this as well. If you could just briefly just kind of go over, because I know these questions came up afterwards, in regards to cortisone injections that we know are effective when it comes to some patients with osteoarthritis. However, there is a number that you want to try to hold off before that cortisone could actually be detrimental. Can you go over those again? And then Dr. Shah, one of the questions that came up and was, for patients who have had a lot of cortisone injections, does that make the surgery that you do more difficult? So Dr. Sall, I'll have you go first and then Dr. Shah to finish.
Yeah, definitely. As mentioned, cortisone is usually many primary care doctor or sports medicine physicians first go-to for an injection because, like I said, it's quick, easy, covered by insurance, and works really well, usually initially, and for a prolonged period of time. I think I mentioned I don't like to do more than 3 to 5, usually 3, in the same joint. So for instance, a right knee, I'll do 1. We have to wait a minimum of a 3-month interval usually before doing another cortisone injection. I like to wait longer if possible. And then again, yes, there is a limit because cortisone injections, I think I mentioned with some of my answers in the chat, multiple or repetitive injections can potentially lead to weakening of the surrounding bones and tissues, which potentially may cause damage as well. So we don't want to cause damage when we're trying to help the patient. I'll let Dr. Shah answer the next question regarding cortisone injections and surgery.
Yeah, I mean, I agree with everything you said. I think that the 3-month interval is reasonable. It's not, people always ask, well, what does cortisone do? We actually don't know. We've looked at studies where you take the fluid out after a cortisone injection, and the amount of inflammatory materials and chemicals that are in the knee aren't any different. So we don't really understand why cortisone works. We know it's an anti-inflammatory. We know that's how it works in general. But why in a joint is it so effective? We don't really know. We don't have good science behind it. But sometimes you just got to do what works. As far as does a cortisone injection make a knee replacement difficult? The only real place, and I actually had this occur to me 3 times today. I was doing knee replacements, and the cortisone deposits in the soft tissues, especially if you use something like, there's different medications, just like you have different kinds of, you have Motrin and Advil and ibuprofen and whatever. You have different kinds of cortisone, and certain ones will deposit in the tissues. And really where it makes it difficult is that the electrocautery that we use during surgery doesn't work as well. But in general, the damage in a knee is done already. The cortisone, if it gives you relief, take it. Don't ever worry. If you end up at surgery, it's not going to make the surgery impossible. And you should always be looking for your quality of life. The surgeon will be able to work around that.
That's a great answer. Thank you. Thank you for that. And then, there were a few questions on here. A lot of them were, when is too old to receive a joint replacement, or is there an age limit? And then also, for our younger patients who may have issues with severe osteoarthritis at a very young age, do we do joint replacements for those folks? Present technology, with good with good rehab and modification to activities, what would be a common lifespan for a total hip or a total knee replacement?
Yeah, age is a complicated question as far as surgery goes. There's two types of age. There's chronological age, which means what year were you born, what year is it now, and how old are you? And then there is physiologic age. Physiologic age is much more important than chronologic age. I have 50-year-old patients who are on dialysis and who are very, very ill. They have heart problems and things like that. They may not even be overweight. They just might have these problems because bad luck, whatever reason. Those people are much more concerning than a 97-year-old healthy person who has a bad hip. I mean, I did an elective hip 2 weeks ago on a 97-year-old. She had really bad hip pain. She couldn't walk. She wanted to go for a walk with her grandchildren and great-grandchildren. She could not. And we did the surgery because she was healthy. So that is really, so the way I look at it is not how old you are, but are you a healthy person? If you're healthy, then we can do surgery. If you're not healthy, we can try to make you as healthy as possible. And then if it is safe to do surgery, we will still do the surgery, knowing that there are additional risks. As you have more health problems, your chance of infection, your chance of having worsening health problems does increase. But we talk about all those things together and make a plan. The patient and I make the plan. I don't make the plan and they don't make the plan. We do it together.
Fantastic. And I know we are up at time, and there are questions that are here that we did not get to, and we will continue to work through. And I know that there will be some communication coming afterwards. But in closing, thanks to all of you who joined us this evening to attend the lecture. The excellent questions. Of course, a huge thank you, a round of applause for Dr. Sall and Dr. Shah, taking time out of their really busy schedules to be able to join us this evening and provide us with the valuable information. We will be sending a recording of this presentation to all the attendees. I know that was a question earlier on, and it will also be posted on our Facebook pages and on our YouTube channel, which you'd be able to access by typing Providence in the search bar when you're on YouTube. As mentioned earlier, there are 17 Providence hospitals throughout California, as shown on this map. And we look forward to being able to care for you and your loved ones. To find a physician or to schedule an appointment, this is important. If you're not sure who you need to be seeing, allow us to be able to help. Please call our patient engagement center. Now, if you're in Southern California, you're going to call 1-855-203-8831. If you're in Northern California, you're going to call 1-844-907-3714. Or you can actually visit us at providence.org and click on Find a Doctor tab in the navigation bar. And thank you again, and really have a great rest of your evening.